Thank you all for joining us to this Manuthera webinar session. My name is Vili Rahkonen. I'm here with our trainer, Mr. Kevin Collet, and we are really glad to see that we have a really nice international audience with us again. Thank you. Today's topic will be the cervical spine and the upper thoracic spine, and Kevin will share us his views and tips and tricks on both on the examining the patient and also the treatment methods and techniques that can be used in that area. For more content, please visit our Learning Hub. You will find the link in the description below. And also for questions and ideas on the future webinars and so on, please use the chat next to you in the screen. Without further ado, thanks again for joining, and please, Kevin, the stage is yours.
Thanks, Vili. Welcome from my behalf again to this webinar. Let's go straight to the subject. Today we're going to speak about the cervical spine. Of course, cervical spine might be the area where we have some symptoms, but we will be interested in also other areas. So we're going to speak also about upper thoracic, shoulder girdle, shoulder blade mostly, and how it is related to the cervical spine. And we're going to see some techniques to do examination using movement and treatment. And we're going to use movement during the treatment as well, having our focus on different areas. So we might use the same movement, but with a focus on different structures. Of course, when we move our head, we have movement in the joints, but we have also movement and function in the muscles, in the nerves. So basically, with changing in our holds, we can focus on different structures using the same movement. So these are some things we're going to speak about today. Now, first, why should we be interested in cervical spine? Well, of course, the patient can come to the practice, to the clinic with pain in the cervical area. Pretty common. It could be in the upper back as well, or it could be in the side, on the upper neck as well. Pretty common cause in the clinic. Now, of course, we can have symptoms as well somewhere else. So we could have facet joint from the cervical spine referring and inducing some pain in different areas. We could have pain in the shoulder blade area, let's say about maybe C5, C4, C5, C6 area. Or we could even have pain in the upper limb, maybe linked more to nerve root entrapment in the cervical spine. So these are of course different causes of symptoms that we can have locally in the cervical spine, having symptoms locally or then in the upper limb, basically. Now, the causes of these symptoms might be in the cervical spine, but the causes behind these could be in other areas. So we know that the cervical spine is very, very mobile, of course, because we do not have the rib cage as we do it in the thoracic spine. So we have a lot of movement in there, and it's an area that will compensate pretty easily if we have some restrictions in the other areas. This compensation can happen within the cervical spine, so we could have maybe lower cervical spine restricted in some direction of movement, and then upper or mid cervical spine compensating in the other direction, for example. So then we could have within the cervical spine the problem. We know that when we're moving the head, we should have also movement in the upper thoracic. So it's not only about moving the cervical spine, but movement should happen up to T3, T4 in the upper thoracic. So basically, this upper thoracic might completely be asymptomatic, but we still, of course, will be interested in this area. So we'll also do examination and treatment, if needed, of this area. Now about the shoulder girdle, if we think about the muscles that are involved in the shoulder blade and having an effect on the cervical spine, we have, for example, trapezius, the superior part. We have levator scapula, a muscle coming straight from the upper angle of the scapula going up to C1, C2, C3, C4. So we have a lot of effect on the cervical spine. So it's also some areas we're going to have a look at. Now, of course, the CT junction, cervical thoracic junction, has a big effect also on function of the cervical spine, as well as the upper thoracic outlet. So important area as well. So it's also something we're going to have a look at. Now, before we start, and we're going to start with the CT junction, before we start, I would like to show you how to position the patient. Now, there's two things to consider. The first one is we can use the twofold possibility of structure, twofold structure of the table for vertical shift. So we can lower one part here and then the second fold here. So if, for example, we would have a very important kyphos in the thoracic area, then we might want to have the head lower like that. So using these, you can adjust for a vertical shift here. In many techniques, I like to have a little of flexion to get some more space for the upper thoracic and the CT junction. Now, the second thing about positioning of the patient is we would like to have the area we want to move, so for example, CT junction, at the level of the joint of the table. So I'm going to ask my patient to come just a little lower here, perfect, so that I can have movement in the area I want. Now, we're going to start with the CT junction, and we're going to focus first on examination. Now, I would, of course, have done my examination standing, and before that, my clinical reasoning, and why would I be interested in the CT junction. But as I told you, if I have symptoms in the cervical spine, I would definitely want to have a look at the CT junction, so cervical thoracic junction. So I'm gonna have a look at the C7 first. I'm gonna put my thumb here on the lateral aspect of the spinosus process here. My hand will have a large contact. I like to have a good focus, but a large contact. So basically my hand is in the same direction here with a good contact close to the spine. And from here, I will open here and keep a good contact also on the head and induce some side bend here to one side. And then I will just keep contact, change my hand, change my hold, and then go to the other side. Now, in that case, I can feel a pretty good movement in both sides, pretty symmetrical here. We'll have a look at then at the upper thoracic, but if we only have some restriction in the cervical thoracic junction, the treatment method from here would be to make it more powerful. First, I like to have the table a bit lower here, and I will have a contact with my hand lateral with this part of the hand here. So I will have a good contact here. I can even focus here with my thumb here. It's not necessary, I can keep it here, but I like sometimes to make it a bit more strong and effective here. Now, if I need a lot of movement, also something to consider is to free this hand and ask the patient to put it under the pelvis area here, or under the thigh. Perfect. Now, it gives also relaxation here, but mostly it gives us space to move. Now, from here, I keep my elbow very close to me, and I come here in the upper corner of the table. And I will try to have a fixation here with this hand and make a circle, having this movement of the table produced from my body here, and to open this other side. So this stays on the spot, fixation, create a fixation, and then I have movement to the side here. So fixation with the left hand now, and movement to the right, having a good control of the head here. And relax. And calm. And relax. So this is completely passive. And I like to come back to pretty a neutral position because it makes it more comfortable for the patient, easier to relax, and then to have a good mobilization here in the CT junction. All right. Now, I will show you from the other side. So I will ask my patient again to change his hand position and put under here. I can even move that support away to get even more space. Again, this hand stays close to my body. I have a good contact with the soft part of my hand here, laterally of the spine. The thumb can make it more efficient or can just be relaxed on top here and having mobilization here to that side. Now let's imagine that I would have a restriction to one side and I can feel that only mobilization doesn't really work and I feel some tension. I can even make MET, so muscle energy technique, out of this technique. So I would bring to the side up to the moment I feel some tension. And I will ask my patient gently to push his head against my hand here. Very good. So it's not a very strong contraction. It's about 20% of the maximum. And he would hold it for about 6 seconds. Now relax. And I go a bit further. You can still be relaxed. Good. And then again, contract, resist. Very good. For 5-6 seconds. And relax. And then I would go further. I really like to combine MET technique, MET, muscle energy technique, with this kind of mobilization technique. I really feel that it allows me then for the mobilization to go a bit further and to get better results. Here, so CT junction, mostly if I notice in the cervical spine some differences in sideband mobility, I would definitely have a look at CT junction. Mostly, I would say if I notice sideband mobility difference in the cervical spine on a large area, let's say this is something that I would see at the clinic, that let's say C3, 4, 5, so kind of group of vertebra that moves more to one side than the other. And then I could have, of course, if I have this situation, maybe because of the stretch of one side, some symptoms on the side which is stretched, so maybe scalene muscles would be stretched or other muscles in this area. Or then I could have facet irritation on the side which is closing to the right side. So in this case, again, if I have a group of vertebra like that, I would definitely have a look at CT junction and upper thoracic for maybe some restriction of mobility there. So this was for the CT junction, and now we're going to have a look at the upper thoracics. For upper thoracic, basically the position of the patient is pretty the same. For examination, I would like to have, you can put your hands back, yeah, all right. For examination, basically exactly the same as we just did for C7. So I will have a lateral contact on the spinosus process with my thumb here, open the movement here of the cervical area, have a good control here. Because I'm moving the head, I don't want to have very fast and uncontrolled movement. It doesn't feel very good for the patient. It's easier to relax when I have a good contact here and have a quiet movement. So I was on C7 at the moment. I will go lower to C1, C2, C3, C4. And as we know, when we move the head, we should have movement up to about T4. So T1, T2, T3, T4. I would check on the other side. Again, I'm trying to have, again, a fixation with my thumb and pushing here the head into lateral movement, lateral bending, side bending. What I should have is some flexibility or mobility here in the upper thoracic. Now, I can feel that here on T4, it's a bit restricted to the right. Yeah, mostly to the right, so, and also T3. So T3, T4 restricted to the right. Now, when I'm here, of course, I can continue the same direction and do this as a very light mobilization. I can push here with my thumb and, again, using my body weight and my hand, moving the head gently to the right. Relax when I come back and push again. If I want to make this more effective, so again, I want some side bend here to the left side of my patient, I was now bringing the head this way, and this is what I'm going to do again, but now I'll take a contact on the opposite side. And I'm going to have a contact here on the transverse process here. So if I want some side bend to this side, I'm going to take contact on that opposite side, and I'm going to help the movement, the gliding movement of the facet here. So if I have side bend to the left, I have a closing here on the left, but I should have an opening on the right side. And this is what I'm going to work on now. Now, to make this, what I don't want to is to really compress here, because this is not really physiological. We don't want to compress a lot on the facet joint, but we're going to have a slide movement. So what I like to do that is to have first the table low enough and a bit of flexion here in the cervical spine, or at least the upper thoracic. Now, from here, I will check for the spinosus process, go lateral on the right side of the patient and take a contact on the transverse process here. Again, I want to have side bend to the left, so I can ask my patient to put his hand here to get more mobility and move this away here. Table should be pretty low, so a bit lower even, so that I can really have, imagine you would have a cravat, the cravat would come on top of the hand. If I'm behind here, my force, as you can see from my hand, is going in that way. So basically, I induce compression of the facet, and it's what I want to pretty much avoid if possible. So if I come above, then my thumb is more pushing into that direction, so anterior and superior toward my shin or toward my own ankle. So I come on top here, one thumb in contact, the other thumb on top of it. I may have both if needed, and I'm going to induce the movement using my leg. Now, when I induce the movement with my leg, I should have movement here. As I noticed a moment ago, there's some restriction. So I'm going to work with my thumb to kind of induce this movement in this area where I felt the restriction. So again, the restriction was into side bend to the left. I have my contact on the right side of the spine of the patient, on transverse process on the right side, and I'm trying to have opening movement of this facet, so pushing here in this direction, in the direction of the facet joint, to have a gliding movement here. So this is something which is pretty comfortable for the patient. And I try to keep it pretty slow and controlled with my leg. And what I want is to have the movement here. Now, if I press very hard, I might have compression here in the cervical spine and too much pressure here. So then it's important to make sure that it's comfortable for the patient and he doesn't feel pain or pressure in the cervical spine. Right? So basically, this is the hold I like to use at the clinic. And I have to say that this is one of my favorite technique and one of the favorite function of the table. This is something I can do in other ways, of course, sitting position with the patients with their hand here under their head. But I feel that for some patients, it's easier to relax in this position and then more specific as a treatment. So here, and again, after, I would again test and check the mobility here. So I was working on T3, T4, upper thoracic, and we worked on mobilization of the joint. It's already a bit better. So it's something that I would work maybe a little more, and probably in this case, I would have a look at T4 with the manipulation first, and then keep on going, checking the T3 and check how it's working. Now, we're going to continue with this area, but we're now going to change our focus from joint level to muscle and soft tissues. Now, if we think about the muscles from the shoulder blade, how do they affect the cervical spine? We often think about it the other way. We often think that, well, trapezius does elevation, levator scapulae muscle does elevation of the scapula. That's what the name means, so that's what the muscle do. Well, basically, if we keep the scapula on the spot and then we think about the effect of the muscles, then we actually move the cervical spine. So the effect of these muscles on the cervical spine is very, very important. What I've noticed is that the levator scapulae, particularly if it's very tight, it will induce some side bend in the cervical spine. And if we have some side bend, we of course have closing of the facet joint and opening with a stretch of other structures on the opposite side. Now, because we don't keep a side bend here, we don't stand with a side bend in the cervical spine, it's very not comfortable and it's not useful. It's not very common to see that. So what we see is basically, if we cannot prevent this side bend to one side, now I make it very strong for the purpose, now we have a compensation here from the upper neck. So basically what we have is a side bend here from the mid-cervical and lower cervical and the opposite side from the upper neck. And what we might have then is pain here, probably splenius capitis maybe here, or even suboccipital muscles here on the left or on the right, because they are very tensed and very stretched on the left side. This even can induce problems in the temporomandibular joint for the jaw. So it's definitely something that might have a big effect. Now, this is something that can be examined in the office with patients standing and lifting one hand. What you might see is a shift here of the cervical spine toward the hand which is flexed, toward the side which is bringing to flexion. So if we have this case, now we'll show you some techniques to treat this levator scapulae muscle. Now, levator scapulae muscle, we could treat it both in different ways, of course. We could have soft tissue technique. For this, it's good to take a little of space above the upper angle of the scapula, because this is not so comfortable. We are going to take it higher. So if we think about the muscle, it's going from here to C1 to C4. So it's going up under the trapezius. So we have to be pretty deep in our contact. And we're going to use some movement again. So same movement as before, but now my focus changed. I'm not again in the same structures as I was. I'm now focusing on levator scapulae. So I'm here with my thumb a few centimeters away from the angle of the scapula. And I'm gonna hold here, and this is going to be more fascial technique. So I'm gonna hold here on the spot, and I'm going to try to slide the muscle under my hold. So for this, I will hold my thumb and bring the head to the right. So again, side bend to the right, holding here, so I have a stretch of the left levator scapulae here. There, again, if I want more movement, please put your hand under your thigh. Thank you. And let's take this away there. So again, I like to have a good contact with the table so I can move the table with my body. I like to have a good contact on the head to make it more comfortable for the patient and more controlled. And then a good contact with my thumb here. And I bring it to the opposite side here slowly. And then I relax and I come. Now this I can modify, use again the same direction of movement, but I can use my patient and to do it active. So basically two physiological principles we can use is reciprocal inhibition. So reciprocal inhibition means if I ask my patient to do side bend to the right, that's the direction, in this direction here, then I should have a relaxation of the left side. So reciprocal inhibition would be that I will ask you, now I would change my hold basically for communication with the patient, easier to make it easier. You will push against my hand here and bring right to your right. Perfect. And come back. And now with this hand or the tenor part of my hand, I will have the same technique here on the levator scapulae. So push against my hand slowly, gently, good, keep on going, keep on going, keep on going, and relax and come back. And again, push against my hand. So the patient is doing now the side bend to the right, and relax. Now I take my hand to show you that I don't keep on pushing. I have the fixation during the movement and then I relax. Of course, good to keep the contact, makes it a bit more comfortable. All right. Now, one thing I've noticed is that patients are very keen into participating, so they push gently here, so push against my hand. Now, from here, what I've noticed is that if now I want to keep a good control and slow movement, it's good now to create contact again and then ask the patient to relax, and then I bring back. And do it again, push against my hand, very nice, and relax. All right, so this was treatment of the levator scapulae using reciprocal inhibition. All right, now, again, I could use another principle, which would be isometrical inhibition. So I would have a contraction here of the levator scapulae. So I could ask my patient to bring the shoulder blade toward the ear. So left, yeah, very good. And then you can even ask the ear toward the shoulder blade. So you have basically both direction. Very good. And then relax. And then I bring further. So now I have a stretch. So I have a contraction of the muscle, 5-6 seconds, relax, and then stretch. So this would be, again, same muscle, different principle, using the movement and using contraction and relaxation. Again, for this area, I could also have a look at the upper trapezius. And for upper trapezius, table would be lower. And I would have, again, movement in the same area. Cervical spine, and I can hold here. And, oh, you can just relax. Yeah, that's good. And then we're going to have, I'm going to move your hands a little toward the side here. Again, we could put it under here. That's probably more comfortable. We could even stay here for the time. And from here, I'm going to have this side bend of the head because of me working on the soft tissue. For this technique, what I like is keep it, again, slow and control, hold here, and bring my body weight toward my back leg. So I'm not basically pulling so much with my hands, but more using my body weight. It makes it a lot more fluid as a movement. Right? Of course, these are things you could change. You could hold maybe from this side, work here on the trapezius, work maybe with this part of the hand, right? You can even change your hold. Okay, so soft tissues, also a way to use movement and maybe active movement or isometrical movement and then relaxation to work on the area you want. All right, now I will ask my patient to come supine. So if you can turn on your back for me, please. Thank you. All right. Okay. Now let's make your position a bit more comfortable. So again, positioning of the patient. If the patient can be comfortable, it's always a little easier than for treatment. So let's put even this on the sides. All right. You feel comfortable? Okay. So again, positioning of the patient, I can use this two-fold structure to have a good position of the patient. Now let's see, there's a bit of extension in the upper neck. I'm going to have it maybe, can you come just a little higher? That's perfect. Here. Yeah, that's good. That's better. Now, CT junction, as I showed you before, in a prone position, is basically something I could work from here too. For this, as the head is not now forward into this part of the table, I like to have my hand under to have a very good control so that I don't have rotation of the head. My contact could be, again, with this soft part here in front of my first, of the finger here, second finger, and laterally, posterior and lateral. And from here, I would again create a fixation with my left hand, keeping my elbows close, and induce a movement into side bend. So again, Same technique as we did for CT junction, but in a supine position. So depending how did you come here, you can work straightly with this technique. Now, for cervical spine, we can use exactly the same hold for mobilization into side bend and examination. So again, same hold, I will show you on the other side. I'll contact here on the posterior and lateral aspect of the spine with this part. Not that part, because this is a bit bony and pretty hard. So I'll turn my hand and come a little to the side here. Again, the other hand is having a good contact under the head. My body is in contact with this part of the table. So by moving my pelvis, I'm actually moving his head. Now, if I don't do that, this is a bit more faster, so this makes it a lot more comfortable. Now, from here, I will change my contact from C7 to C6, C4, C3, etc. There. Now, for upper neck, it's a bit different. We have mostly in the atlantar axis rotation and in the occipital axis more this kind of extension flexion, little of side bend movement. So using this movement, I will concentrate on the lower part. So C7 up to C3 movement. C2, C1 again would be rotation. So I would consider only this area into side bend. I mean, not the C2 into side bend. Here, again, I can use this movement that I did as an examination and work on side bend here. I can feel that here there's a little restriction to the left in his lower cervical spine, so I can work on mobilization. So again, my left hand is creating a kind of focus here and fixation, and with my body I'm trying to create a movement around this point. So what I don't want to do is to push far with this hand here, because I have basically a closing of the facets on the left side when I'm having side bend here. So what I don't want is have a closing and to push. It would be a lot of pressure. So I'm more willing at having a fixation here on the left side and opening the right side. Again, same principle. We can change this mobilization, basic mobilization technique using MET. So I would ask my patient, again, to push to the right with his head. So I bring up to the restriction. Then I ask my patient to push. Again, that's very good. A little lighter will be enough, about 20%. 5 seconds, 6 seconds, relax. Good. And then I go a bit further. So I can use a MET technique. And then when I feel relaxation, I can work a bit further here. So when would I do that? If my clinical reasoning tells me that, okay, this restriction here to the left is meaningful, maybe because I have here on the right side some facet joint being very under pressure on the right side, so I want to have mobilization to the opposite side. You could think even maybe about a nerve root on the right side being pinched, and you want to have a little of space created. Again, if it's very irritated, I would do this very gently and checking for the symptoms of my patient. And make sure that I relieve, that I don't produce more symptoms. Probably I wouldn't work too much on this area if there's the nerve root irritation. I would make it a bit more gentle in this area and work on these other areas if there are some findings. Now for this area again, if I think about what muscles I could work on, and which are again very important for the cervical spine, would be the scalene muscles. For the scalene muscles, if we think about their effect and their function, of course, the anterior and medius goes onto the first rib, and the posterior goes on the second rib. So basically what they do is they lift the ribs up high when we're breathing in. Now, they shouldn't do this too easily. They should get involved not only when we need a lot of air inside our rib cage. But sometimes they do work a lot and they get tensed. So what they would do is also, if there is also only one side tensed, they would do side bend. So again, if I want to work on these, exactly the same principles that we see on the other side, I will have my thumb on the scalene muscles, so right behind the sternocleidomastoideus here. And if I want to use this reciprocal inhibition principle, I would ask my patient again to bring his head to the left. Very good. Continue. Keep on going. Very good. And relax. And with my thumb, I try to keep it on the spot, on the surface of the scalene. So I don't push too hard, but I'm not just on the skin. I go up to the scalene, and I try to keep my thumb on the spot, and the patient is moving his head to the left. Again, push. So I have a very nice facial technique, myofascial technique on the right side here of the scalene muscles. Right? Again, if I would have, let's say, entrapment of a nerve root, which is pretty common, even probably a lot more common in the cervical spine than disc bulge. It would be the opposite in the lumbar spine, but for cervical spine, probably more common with entrapment of the nerve root. So basically what we have is a guillotine effect here at the foramen. So what I would have is, for example, C5, and I would have patient with symptoms in this area, and I would have done my examination and making sure that these symptoms is coming from the cervical spine and from the nerve root. So probably compression makes it worse, distraction and traction makes it lighter. So basically what I could use for this kind of symptom is traction. For using of traction, I will open here. So push and turn, so it stays open. So it will work like that, and then this will be moving. Now the head of my patient will stay here on the table, and I will take contact here under the jaw. I like to have the table pretty high and be in a very comfortable position here. I will grab the table here on the side and just gently bring my body weight to my back leg. Here, I want my patient to feel comfortable in this technique. So please raise your hand if you want to say something and you don't feel comfortable, because in this position you won't be able to speak so much. And this, depending on the protocols, maybe of the case, I might hold this for 10 seconds, 20 seconds, have a little break, and repeat this a few times. Basically, this also works as a test, and if I have a nerve root entrapment and compression makes it worse, usually distraction makes it easier. I can change and make this a little bit more specific to some areas. I could take a little of side bend and pull. Usually you don't need to, but maybe if you want, you could. So you could take a bit of side bend and lock it, and then again work into traction. It could be a way. Another way, another particularity, if you want to work in the lower cervical spine and have some traction in there, you will raise a little the table. So again, I will work with the two-fold structure here to make it a bit more, bring the cervical spine into this kind of position with the head going into, our cervical spine going into flexion. And again, from here, hold from the table with your forearms, hold under the chin here, and bring back here. All right, so I'm coming here into traction this way. For this technique, the hold I particularly like myself is having a hook here under the occiput with the thumb on one side and middle finger on the other side under the occiput. So close to the cervical spine, close here a little with the hand, go up until the occiput comes, and then you have a good hold. So one hand is there, no side bend, no rotation, other hand under the jaw, and I pull again behind. Now this flexion allows me to focus more on the lower part of the cervical spine. So C5, C6 here, which are basically pretty common if we think about nerve root entrapment. All right, so to finish, I bring it here, come back to neutral position, and welcome video again.
Can I have the mic?
Yes.
Thank you. Thank you, Kevin, for really being really specific with your techniques and explaining why we do things like this. And it was really, for myself also, we got some really nice feedback from the audience, and I'm sure these are really common problems that our professional audience face daily in their practice. And for me, myself, it was really nice to have also a nice recap on the anatomical point of view and the mechanism, how the cervical spine and these muscles work in a functional way. So thank you for that. And hopefully all of you enjoyed this webinar. And again, for more content and more techniques, you can visit our Learning Hub. Again, the link is in the description. And until next time, we want to thank you and take care and see you again. Thank you.